second lecture. Okay. We are in the second lecture in a series. I look for these topics to discuss an issues which is uh, uh, under the umbrella of cardiac surgeon and cardiologists that are sharing the same concept and they have the same uh, um, issues of in the management. So those the area which have some complexity and which need good cooperation between the cardiologist and the cardiac surgeon for a better outcome will be discussed in more than one lectures. The first one was regarding the life-saving events between the cardiologist and surgeon, and today we are going to discuss the AV canal complexities regarding some important issue which we the surgeon want to know from the cardiologist and the important points which the cardiologist should be concentrated, which will improve the outcome of the patients. So it is a point of sharing knowledge and making a multidisciplinary team, which will help modeling the team-based work and between the cardiologist and cardiac surgeon and giving a good outcome, which proved to that when we the work in form of team models, the mortality will be decreased and the hospital ICU stay will be decreased and the risk of revision, surgical revision is less than third almost. There is many points and many complexities which need to be clarified between uh, both teams, both members of the teams. I mean, the cardiologist and the cardiac surgeon, and because they are the team based on those complexities have a difference in the surgical planning and surgical outcome of those patients. For example, which the approach driving protocols which should be implicated like in hypoplastic left heart syndrome, TGA with VSD, LVOT obstruction, single ventricles and heterotaxia, Down syndrome with single ventricular pathway, TOF with MABCAS, DORF, truncus arteriosus with the AV valve pathology, interrupted aortic arc, corneal displacement with VSD, ALCABA, IBST, mitral valve repair, and rheumatic, pediatric, TGA with intramural coronaries. All of these issues is not straightforward pediatric cases, and all of them they are high risk, and all of them they need a sharing knowledge to improve the surgical outcome of those patients. What's about AV canal complexity? I will concentrate in three with once there is a VSD with the tongue of the tissue connected between superior and inferior, this is an intermediate. And actually, when you look for this for the lesion in this way, you feel okay. It's we are going. You have a defect. We are going to close it, and we have a valve. We are going to separate it. So let's to plan, but the planning in the space, and this is not like this. Is not simple like this. Whatever the way you are going to close it using a double batch technique or double batch technique or single batch technique or modified single batch technique, just for knowledge modify single batch technique that we are pushing the AV valve toward the crest. So we suture it to the crest and using one batch then to close the atrial septum to separate the atrial septum. What I want to say that if you look for the AV canal in this way, you will feel okay. This is the simple and basic, but actually the outcome is not depending on the batch you are closing or the valve we are separate because there is different morphological feature related to the AV canals which affect on the outcome of those patients and the surgical strategies. Even when we feel that the LV or and the RV are a good size and looks to be can be septated, but you are going to close the AV valve and you found the inflow of the LV is not enough or the inflow of the RV is not enough and hypertrophied. Those factors should already was discussed in details, and a lot of cardiologists they they went in deep looking for this and stressed on these issues, to get the best assessment of those valves which may affect and for the outcome, and give a good plan for for the surgeon while he is in OR, rather than to come with a patient with post-op in different physiology, and on those patients usually the risk become post surgery is high, and the revision has high mortality. So what's the hallmark that AVSD was shared through? Let's to say start with the AV valve. The AV valve is not two AV valve. We are going to separate it because the level of AV valve are different. They are a little bit pushed toward in the same level, rather than to have right valve toward the apex and mitral valve toward the base. So both of them at the same level, and there is a deficit in the AV septum. So let's stop here. So the AV septum is deficit. That's the inflow, which is the AV septum is controlling. Part of the inflow is deficit. So the batch we are going to put it there will be effect to the inflow. So even sometimes you'll have in OR a good case. The VSCD has large VSCD, and the AV valve index looks okay. But once you put a big batch and you don't concentrate on the batch, is either redundant big batch or smaller batch, or which keeping with putting some restriction on the leaflet, the end by that's the have problem in the inflow because the geometry of the IV valve will be changed. The IV valve will be switched for to this patch. Plus, this if the septum is hugely deficit, and this batch will be part of the ventricular septum, maybe the cardiac output will be low, and maybe the low cardiac output because part of the septum replaced by synthetic tissue. So changing in geometry will be affected, and also the VSCD large VSCD may affect also on on the cardiac output. This is a point, but this the other points we should be taking into consideration that this this VSD also will be affect on the LVOT tract, and maybe because the the part of the inflow septum is deficit, and this inflow septum which was deficit, and the AV valve which was pushed little bit lead to displacement of the aortic valve, and the aortic valve will become more anterior and high, and as he is pushed away, he become unwedged, and unwedged aortic valve lead to the engagement of the LVOT. So it is also that he has the LV will be under stress with outflow. So if you expose for a VSD patient with a large VSCD, and he has a coarctation history of coarctation, this is a high risk patient. You should take it in your consideration because the patient with coarctation maybe also he have small LVOT, which already morphologically was elongated. This patient will be a risky patient for developing LVOT obstruction in the future. Even he will become okay, smooth. He have smooth postoperative course, but they have tendency to develop LVOT obstruction. So it is part of a significant part of developing and the risk of redo operation and LVOT obstruction. This is so it is one factor will build the other, and the two factors will make the complexity more and more, and will change the plan of the surgery. With the point is not only the inflow with deficit AV valve. The point is not only in the outflow with the unwedged aortic valve and narrow LVOT. It's also in the on the papillary muscle. The papillary muscle in the AV canal, they are displaced in counterclockwise rotation, so they are not close to the septum, rather than rotated in clockwise fashion. As they are rotated to clockwise fashion, they attach to the become more approximated to each other, and they are attached to what we call the mural leaflet. This mural leaflet is part of the in the normal people part of uh, posterior mitral leaflet, but in AV canal become mural leaflet. But and it so just imagine if these two papillary muscles are close to each other, this mural leaflet, which is very important to maintain the coaptation in those patients. If we lost this or become dysplastic or small, the coaptation zone will be low, and the patient maybe will end by mitral left AV valve stenosis because of after closing the cleft. Cleft itself is another issue. Cleft is not directed toward the aortic valve as usual. It's directed uh, like a congenital cleft mitral valve. No, it is directed toward the septum. So once you close it, this cleft is a part of the coaptation zone. So the stress on the suture post-op will be over the cleft because it is in the coaptation area, and that may will change the decision. Shall we close this patient early while he have a unit with a small thin leaflet with risk that the systolic pressure in ICU high, he may tear. I have a patient, I close it, doing it nicely. He have trivial mitral regurg, second day post-op, he has moderate mitral regurg. Could be because the patient over the night he had high pressure, and this small thin leaflet on 4 kg patient teared, and the patient will have mitral regurgitation. The point here that cleft is part of the coaptation zone. So shall I close the cleft, the whole cleft? Shall I accept and not closing the whole cleft because the mural leaflet is small? So a lot of points should be discussed in deeply with the cardiologist, and the cardiologist should not go just throwing parts pieces of the information without say looking for its significant and feedback. But another point, anatomical or morphological point to be discussed, maybe it's not so important if from surgical point of the view, is the Rosselli classification. We have A, B, and C. In C, it is a floating leaflet. The bridging leaflet is a floating. So the Rosselli is related to the attachment of the superior bridging leaflet to the crest. So if the attachment almost to the crest from each side, this is a type A. Once there is no attachment, it attached to the free wall. This is a type C. The type B usually attached to the other side. This lead to the type B. You will see it more in imbalance. So if you looking in econ, you feel that this patient most likely to have a type B. You will keep in mind about LV inflow index, because maybe that's lead to the inflow mainly to the right, and patient has right dominance. You will look for AVVI index and assessing the secondary annulus and looking for AV left ventricular inflow index LVII. While in type C, this patient is at a floating leaflet. As the leaflet is a floating, as I explained to you, because of deficit AV valve, if the leaflet is a floating, so it is away from the left LVOT, that those patient is unusual to have LVOT obstruction, less likely to develop the LVOT obstruction in the future, not like type A or type B, where the leaflet is attached to the crest and narrowing the LVOT. So maybe from this point of view, type C, which is common with patient with Down syndrome tough, and while the type A, which is more common in the AVSD in general. The point now to be discussed, not like this. So we said, okay, this is a classical talk. AVSD, 4 parts, batches, different hallmark anatomical morphological features, so maybe will affect our outcome. But the point which make the ABSD complexity and the decision taking is difficult is the area where you don't know is this patient is going to biventricular or single ventricle. The criteria you are have is enough for septation or not, and which is the best time for surgery. In general, the time of surgery was solved for a long time, as they noticed over the years and years that the mortality of this patient is decreased, and the technical surgical technique was improved, and the weight of the patient become less and less, and the STS database showed that the total mortality of AV canal is around 2.7, with an update of last 2019 STS database is 2.4. Let's to say that the mortality average between 3 and 6, 3 and 5. This is usual when you have a weight more than 3.5, and when the age is more than 3 4 months. which become the standard to do it on 3 to 6 months. So let's to say that the age is little bit solved, but as a standard. But sometimes you don't need to you are obligatory to delay the case. You are not going to do it as early because you have the patient has some comorbidities, and these comorbidities maybe delay you from doing it an early as 3 months, and you push the patient toward 6 months. Another point to discuss here. Okay, you said this patient with transitional AVSD, or let's you say patient with partial AVSD, he has a shunt through the ASD, and those patients you can delay them. Yes, you can delay them. Let's when to do it at school age, like an ASD. This is a concept we should be discussed between. It should be clarified. ASD is secondum, or ASD primum, or partial AVC is not an ASD secondum. Yes, there is a shunt through the ASD, but the morphological features of both valve is different. The cleft in partial AVSD, which I told you that this cleft is toward the atrial septum with the coaptation zone with the risk of regurgitation. Those patients have high risk of developing of regurgitation and secondary changes, and those patients would usually have an AV canal, and have tendency to be a down patient, and the shunt through the ASD is huge. So the regress from mitral valve and shunt through the left to right will end to chamber dilatation. Secondary chamber dilatation will lead to the annular dilatation, more regurgitation, and it end by severe secondary changes, and with the long-term outcome will be affected during surgical repair. So you will not push this patient to the school age rather than closing to 1 year. Even some of the centers they like to do it an early. Another point to be discussed by surgeon, because this is a very strong argument. They believe that even you can do it an early as soon as possible within 2 to 3 months, because they believe that once you septate the atrial and the septum and the valve with before the regurg for long time, you will avoid secondary changes, avoid development of pulmonary hypertension. And a concept should be discussed with this. You will hear it many times from the surgeon. It is not uncommon to hear the surgeon make the comment that there is inadequate atrioventricular valve tissue. This observation could be due to annular dilatation, which reach to the point that there is no more coaptation. That's why by this point, they stress that to do AV canal repair as early as possible. But uh, you adjust your result in the center and your ICU capability, and your patient comorbidity. If you feel that this patient is weight is very low, you will push the patient toward for six months. But if you feel that this patient is in a good weight, have no other comorbidity, you can go with as early as 3 to 4 months rather than 4 to 6 months. And uh, most of the paper they are pushed toward around this weight, this age, and really they push away from toward 9 to end of the first year. So from point of time of surgery is clear. But if we have other factors apart from weight and age, like this patient, she has narrow LVOT, and you feel that the VSD is large, and the aortic the ventricle is, you don't know, maybe is hypoplastic or borderline, and you are in doubt for to do full septation. One of the surgical strategy on those patients may to close the atrial septum and to septate the both leaflet, both valves, and to leave the VSTD, which give you a time to assess the left ventricle, if you're going to grow and the LVO is going to be narrow or not. This is a point on the borderline. It's best to have one step back rather than to do unplanned biventricular repair, which may will end by worse outcome. So uh, this is a point of the time of the intervention, but how we will assess if our intervention is or correct and our surgical strategy is correct, either to biventricular or sagittal ventricles. We need a perfect assessment to plan the ventricular septation and to avoid false pathway, which may be lead to poor outcome. Actually, there is a lot of variables, and there is no perfect assessment. There is no perfect assessment. There is a lot of um, uh, assessment tools, and let's to see a good tools to have idea about the uh, post-op hemodynamics, which or LV volume, which may help you to direct you toward the left or right. And because the variables toward the biventricular or single ventricular pathway, because there is a lot of variables which will affect on you. This is you will not reach to 100%, and your guess you will not truly true all the time that this patient will go biventricular. It will never be by a single ventricular pathway. You will have surprise. You will be surprised from now and then. And although we will have a lot of tools to evaluate the inflow, the LV volume, the LV development, the LVOT. But when you see some factors in you with your patient, you should just keep it in your mind and double check the plan. That the patient with Down syndrome, for example, those patients will have usually risk of pulmonary hypertension. Also, they are type C, but and they have a good tissue. They are nice to be repaired inside OR, and they have a tough ICU course, but are more suitable tissue valve in OR, most of them. But they have tendency to develop pulmonary hypertension. So those Down syndrome should be pushed away from as much as we can from single ventricular pathway. And if they are for biventricular pathway, then they develop AV valve regurgitation. The pulmonary hypertension will development will be significant even with over the time, even with moderate regurgitation. As we have a recent patient now, he came with severe pulmonary hypertension, liver to the mid of the abdomen with severe otitis because of the 1.5 year of post-op moderate regurgitation with the end by severe pulmonary hypertension. Other points, as I mentioned before, is the patient developed coarctation or there is a risk of LVOT obstruction in the future. Is the patient has RVOT obstruction, I mean, a TOF. So this patient with TOF, you need to repair the inflow and the outflow of the RV at the same time. And this is the best. This is the bad combination because you will have a free regurgitation from the pulmonary valve. And also, if you have a tricuspid regurgitation, you will end by severe failure of the RV. So that's why you need to push it a little bit away from the from the 6 month. Even if he's maintained, you can push it at the end of the first year. So to keep as if the patient is tolerated so you have more than option for regarding the RVOT reconstruction. Also, you need to assess the efficiency of the inflow. For example, maybe you have good LV size, and when you assess the inflow, you found the inflow is low, so you have to look direct to the VSD from where the LV is getting the cardiac output. Most probably, the flow is coming from the through the VSD, so he has a right to left shunt, which lead to development of the good LV size. But when you're going to septate this LV, you will end by severe left AV valve stenosis. Heterotaxia is another point. You should always keep it in your mind. Patient AVSD heterotaxia, step back and look for risk of single ventricular pathway rather than biventricular pathway with risk with high risk single ventricular pathway. So whatever you are going to look for AVSD is not a simple, straightforward cases. If you are going to choose two ventricles, it is very difficult to and not easy to decide the severity of ambulance if he's a borderline. And this patient, you need to look for subaortic region for the AV valve, for the hypoplasia of the left LVOT. You need to look for the cleft because this patient may be developed left AV valve regurgitation. If this patient developed left AV valve regurgitation post-op immediately, they have risk to need for re-intervention or re repair or left AV valve replacement in the future. Also, those patients still has the risk of pulmonary hypertension because of regurgitation. If you choose a single ventricular pathway, also this is a risky strategy because those patients, especially if they are down, once they want single ventricular pathway with AV valve, not unusual valve. This is not tricuspid atresia with normal mitral valve. This is an AV valve, which is, as I told you, it is totally geometrically and morphologically is different from AV valve. It will leak and will end by AV valve regurgitation, which may be to pulmonary hypertension in single ventricular pathway. So AV valve regurgitation can worsen after surgery, especially if the patient the AV valve have regurgitation pre-op, and more likely to have reintervention in the future. So as I told you, there's no single factor to assess the balance or which strategy will be succeed in this patient. It is not a formula, like it is an algorithm assessment. You will not say one plus one is two. No, you need to add one, then one, and then you say most probably this patient will be fit for this category rather than to the other categories. This is the AV valve area. You will look for the VSD and you will see, for example, this VSD is deep, large, more than the length of the VSD, more than the AV valve or more than the half of the AV valve. This is a risky septation. You will look for the angle of the RVLV angle, if it is wide or more close. The group that they are more wide angle, they are going biventricular successful for biventricular pathway. A lot of echo evaluation are used to assess. So most of them, they are using the AVVI index, which you use from passive view to assess the LV inflow. And they modified those index to modified AV5 index, and they found that most of them, the biventricular pathway patients between zero point 0.4 and zero point 0.6, those who in single ventricular the red or biventricular the blue between 4 and the 2 are less, but and they have risk bad outcome. Those who are more than zero point 0.6, which most probably they are left dominant, they need to go in band. So a lot of index to assess the inflow capability, but it is enough. It is not enough because sometimes, as I said, the VSD size will affect the valve, the geometry of LV itself, the effect of the septum. Those patients usually they have high QBQS, RV are distended, pushing the septum of the LV, squashing the LV. It is very difficult to assess also the volume of this patient if it is capable or not, and it will affect also the inflow and outflow. So is the AVIVA, the BVI index is not enough, and maybe you need to go further and look for other parameter before you said, okay, I'm sure 100% most of this case will go for biventricular repair. Uh, the LVII, the left ventricular inflow index, they are measuring the inflow of the 2D left AV valve and the color AV valve. And those patients who have, if the color is less than half of the true AV valve, left AV valve, most of them, they will not maintaining on the biventricular repair. This is the group which most probably going biventricular repair when their angle is more wide, around 140 plus minus 12. So is more than one factor. There is no perfection. There is no one single assessment, and you will go factors by factor, assessment by assessment, till you have most probability of the biventricular repair. This is the normal two papillary muscle. When the papillary muscle, this is the posteromedial papillary muscle close to the septum, and this is the other anterolateral papillary muscle. But once you have they are going into counterclockwise, and they are attached to the mural leaflet. This is the mural leaflet. So if the mural leaflet becomes small, and the counterclockwise rotation is more, and they are approximate to each other, it will end by almost single papillary muscle with making a parachute like, or it will end by small mural leaflet. And once you close this cleft, and this mural leaflet is small, which part of the mural posterior mural leaflet in neural mitral valve, it will affect on the coaptation, and it will lead to stenosis, left AV valve stenosis. Okay, now I need you just to have a deep breath, remove all of the things below your machine, and just to come to the real heart, and to apply what we heard and discuss it on the normal anatomy. This is the normal, beautiful, smiling baby mitral valve. Look, a very beautiful mitral valve. The posterior mitral leaflet is almost two-thirds of the annulus. This is the anterior mitral leaflet, huge, covering the most of the two-thirds of the orifice. And this is the aorta, this is the mitral, this is the tricuspid valve, this is the area of the AV valve, sorry, the AV node, this is the coronary sinus. So it is in the apex, it's located in the apex of triangle of Koch. The aorta is not wedged, sorry, its wedge is not high, and there is a aortic mitral curtain, aortic mitral continuity. This is a beautiful normal anatomy. And this is same. This is the membranous septum. This is the aorta. This is the tricuspid valve. This is the mitral valve. This is the normal papillary muscle I told you before. This is close to the septum. This is the posteromedial. This is the anterolateral. This is attached. This one attached to the commissure. This is both of them attached to the one commissure, and this one attached to another commissure. And there is a good space, and both of them are holding nicely to attach nicely to the anterior and posterior leaflet. So this is more to be a four-chamber echo. This is the mitral. This is the tricuspid valve. This is the offset of the tricuspid valve down, and this is the mitral is high, and this is the area of membranous septum posteriorly, or the inlet septum, and with part of the membranous septum. Okay, come to the AV canal. Look for this ugly picture, like a fellow's post call. Uh, this is a bridging leaflet, superior bridging leaflet. This is the posterior bridging leaflet. This is the mural leaflet I told you about. Below is the VSD, above the is the primum ASD, and you need to go to the OR and to septate this valve into two, one to the right, one to the left. If you septate this one, it will be trifolate, mural, anterior bridging leaflet, superior bridging leaflet, and posterior bridging leaflet. This is the normal mitral valve, and this is the mitral valve after repair. This is not the same. See, this is the coaptation line, and it's distributed for all over the huge posterior leaflet, which supporting the mitral during systole. While this is the cooptation is coming from the cleft. This is the cleft you close it up to here, and this is the area of oppositing zone. This is the cleft which is closing, starting from here to here. And this is the area of under the pressure will be if the which is the cooptation opposition, and this is the mural leaflet. So this point is the area where the cooptation will happen. So if this one is small, you will end by superior bridging leaflet is close to posterior. So the total area is small, and patient with stenosis. If it is dysplastic, if it is dysplastic, if it is huge also, it will maybe sorry, if this one is distorted by secondary leaflet, the repair will be difficult, because also the cooptation zone is in this area, which usually have mitral AV valve regurgitation. Again, you have AV valve. This is the left side, this is the right side, and this is the bridging between the superior and inferior, which usually occur intermediate. From this area, from this point, the idea is coming, why not to septate the valve and let the flow going through this one to the LV, and from here to go to the RV, and the LV will declare himself. He will can grow, and later on we can go to septate when you have a small baby and you think this patient borderline. You are not sure that this patient can be septated or not. This is the normal inflow, outflow is equal from the apex to the inlet and outlet. And this is the AVSD, where the aorta is high and the outflow is narrow, and the inflow is disproportional to the outflow. Sometimes the cord is attached to the crest, and attachment of the cord to the crest, which with the VSD is situation where is a deficit lead to narrowing of the LVOT, and that's why sometimes if you remove this chordae, it will help to displace the leaflet away and open the LVOT, as I will inform you later on. Look for LVOT. You are cutting the heart and looking from the heart to the heart from the apex, and this is the aorta. This is the mitral, anteromitral leaflet. This is the curtain. This is the aortomitral continuity, and this is the AVSD. Aorta is far away, and this is the cleft. This is the superior bridging leaflet, and see the attachment of the to the crest. If they are attached, it will cause uh, narrowing of the LVOT. This is the mural leaflet I told you about, a normal. Look, this is the LVOT, small and narrow. This is the septal leaflet with the dropout VSD. This is the cord attached to the crest, causing narrowing of the LVOT. This is the LVOT with the cord attached to LVOT. This is the aorta, so how it is crowded and narrow. And once you displace it, it enlarge the LVOT. What about the ostium primum? This is the coronary sinus, and usually in normal, the AV node will be here in front of the coronary sinus in the triangle of Koch, while it is displaced posterior inferiorly. I will tell you what the significance of this. So it is more displaced posterior inferiorly, and that's why sometimes you need to go around the apica, the coronary sinus and displace the coronary sinus flow toward the left, and the patient may have a 2-3 degree of desaturation. Same, this is the ostium primum. You are suturing here over the AV valve. So in AVSD, in ostium primum, you close the cleft and you close this. You suture the patch over the AV valve, which make it is not the case in case of secondum ASD when we have the whole secondum tissue or close to the IVC floor, so there is no attachment to the AV valve. So maybe now you are a little bit oriented about what we are talking about. This is the AV node. Look how long is the track. Is because there is dropping the inflow, the inlet septum, it travel for long distance over the crest. This is why the patient have a prolonged BR interval, and because of the long also the patient will have because before septating to the left and right bundles, the patient will have left axis deviation. David Overman, he's a famous surgeon. He wrote about how they will deal with the LVOT, and he drew a nice cartoon, the difference between left LVOT obstruction in usual and those patients on AVSD. This is the usual. This is the aorta, and this is the mitral leaflet attached to the aorta. And when we have subaortic membrane and fibromuscular ridge, we came here and we shave it till we reach. Sometimes it's attached to the mitral valve. We shave it from the mitral valve, but the whole area, all area is open. But when you have a patient with AVSD, the anatomy will be different. This is the superior mitral leaflet, superior bridging leaflet. It's attached to the crest nearby, and there is anterolateral muscle. Maybe they call it molart. And if this become hypertrophied, or the ventricle become hypertrophied, or over the narrow of LVOT or abnormal papillary muscle, it will develop LVOT obstruction. So we discussed regarding the time of intervention and the risk of balance imbalance and strategy of balance imbalance. Also, the risk of those patients which have criteria for developing LVOT obstruction. This is a famous paper. The big surgeon, all big surgeon was here in this paper. I don't know why all of them they are coming in one paper like this, but it is very strong because they bring the solution for a complex nightmare pathology for a surgeon. And they found in their studies that those patients who has LVO2 obstruction post AVSD, most of them they have very high mortality and over the time. And so the planning from the beginning for and assessing the risk of developing with LVOT is very, very important. And this is a nice cartoon from the same paper, and they bring the concept of the normal and abnormal, how they will deal with it. This is the LVOT with the normal LVOT, and the septum is not deficit, and the mitral is away, and this is the angle of the outlet plan. Once in patient to an AVSD, it will be like this, very narrow. So what's the option? Either to cut this leaflet and push it away and making an augmentation, or to do resection, or to open this area and to patch it, what we call modified cono. This is the case of myectomy. You'll open just a little and the LVOT will be enlarged. Okay. If you augment, it will enlarge more. If you do both of them, you cut and you augment the leaflet, it will enlarge more and more, almost to the normal. One of the other options is to do what we call the modified cono. You cut down and you batch the LVOT. And in severe cases, when the aortic valve is small, maybe you will go from the conurus. Nowadays, the strategy I will show you in the last paper last year, the points to go for the Norwood from the beginning is in the table, and they bring a good result with Norwood, planning Norwood from the beginning. Okay. Interestingly, rarely you found this LVOT obstruction because the leaflet is a little bit away and the angle of outlet septum is wide. As Mary Cohen, she was the best one who wrote in assessment of balance. I think Jeannie, she has a good papers regarding the from Emory schools regarding the assessment of LVOT obstruction, and she studied all of them in retrospective case control studies, and she tried to pick up which the strongest indicator that this patient will develop LVOT obstruction. Is it the inflow outflow ratio? Is it the angle itself between RVN and LV? Is it the septal aortic angle? It is the displacement. All of them could associated with. Plus, there is some anatomical factor like narrowing the LVOT itself, abnormal biliary bustle, hypertrophy of the septum. All of them could lead to, but she studied the other echoes parameter, and she found the most strongest indicator is that when the index LVOT is less than 2.5 preoperative before VSD closure, because this patient most probably will develop LVOT obstruction, or when there is a cord crossing the LVOT, most probably this patient will develop LVOT, significant LVOT obstruction. Up to date, what's going on now? This is the last two papers was discussed regarding the using of MRI in assessment of biventricular repair. Instead only to trust and depend on echo assessment, we have MRI tools. Why not to use it to reinforce multimodal image and assessment the volumes of the LVOT, and a control study with the echo index showed that have a significant in the taking a decision regarding balance and imbalance. This is the 20 was published last year. Another new papers was discussed was just was published is using an arch repair Norwood in imbalance patient with coarctation. Instead to go to do coart repair and band, they assess those patients to using Norwood from scratch. So start with Norwood rather than to doing be a band and coart repair and assess and develop later on LVOT obstruction. And from the study they saw there is highlight the Norwood as a preferable as strategies and better survival than use usual standard using coarctation and be a band and future assessment. So it's a complex. It's not only batch the VSD, batch the ASD, septate, the AV valve is a collaborative management between cardiologist and cardiac surgeon, is a basic pathophysiology who need to be understood nicely, and team approach between cardiologist and surgeon will end by efficacy of surgical intervention, and it enhance a good long-term outcome. Thank you.